like the journey I've been on for the last 30, 40 years, right? That's the first thing. And that's why when I
Mm.
met Clean, I went, oh, wow. There's a lot of stuff coming into my mind as you talk. Um, the first thing is that no, there's two arrows going, or two flags. Let me say two flags that I have found that need to be recognised in the context of delivering diabetes care.
Mm.
The one is the flag that was raised up by a guy called Bob Anderson, who worked with Marty Funnell, who used to be, she may still be, although she's similar age to me, so may have retired. Used to be, they're both American. Sadly, Bob's died, but they did a lot of work around a concept called diabetes empowerment. And so they at the time, this was 20 plus years ago, more than 20 years ago, they were also saying the compliance model, the medical model does not fit. So let's have another model. So they developed an empowerment-based model. They did a lot of work around it, and they did a lot of training
Mhm.
across the US in order to get healthcare providers using a more open model to help people explore um, the barriers to diabetes care, what they wanted to have happen, and the notion of life experiments, if you like. So, how did that work for you? What needed to change? And I got quite involved with that because I'm a great resource investigator and brought that workshop, well, experienced it over in Sweden. I had a lovely few years in my, well, I've had a lovely career. Experienced it in Sweden, brought it back to the UK and started to do the same thing. Couldn't get national funding, but we got, sadly, industry funding from a glucose monitoring company. We
Mhm.
managed to roll it in and we had it part of a course. And we experienced the same thing, that there was a lot of interest. But what Bob and Marty found when they actually researched what happened by I think they audio taped conversations, they found that actually there was a real struggle for healthcare professionals to change
Mm.
based on their own paradigm. So what they hadn't done is reflected on who they were when they come into the room,
Mm.
right? So that's the one flag.
Professionals had not reflected on who they were when they came in the room.
Yeah, yeah.
Okay.
Right. So and in order for you, so they still use this beautiful laid out described model to try and get people to engage, but they still wanted to fix it. They still wanted to fix it. They still believed. So there's this real tension between nurses, doctors, and dietitians and podiatrists to know that they know the right thing, and if only people would do the right thing. So there's still this tension. The other thing for me, so I don't know if you picked up, I did a PhD a few years ago with the University of Leicester and Leicester Diabetes Centre, and that came out of some work. So this has been a lengthy journey. I was part of a program called the Desmond Education Program, still around,
Mhm.
education program, and we developed it actually in Portsmouth, but it was adopted by Leicester because they were trying to collaborate a number of centres across the UK to do something around type 2 diabetes education at diagnosis. And we developed, they took our program because ours was psychologically based. A lot of it was based on an empowerment model.
Mhm.
It was 6 hours long, so people turned for the whole day, and the rationale for that was if you're going to take this seriously, if we want people with diabetes to take this seriously, the system has got to behave as if it's serious, right?
Yeah.
And it
Yeah.
wasn't, right? You
Mhm.
know, we had GPs that would say, well, I tell my patients it's as serious as if you've had a heart attack, it's the same risk for another heart attack.
Mhm.
I said, but you don't behave. The system does not behave as if
Mm.
you've had a heart attack. If you've had a heart attack, you go into hospital. Boom, everything's around you. You're scared, you're frightened. Do even then, people don't always change their behaviour. I
Mhm.
said, all we do is you send somebody 3 weeks later to see a nurse and give them a diet sheet or something. That's
Mm.
not telling people it's serious. So we said we wanted a programme that you came to and people came for the day, right? So that's
Mhm.
what we had. And so we got national funding. We did really well, lots of publications, can send you one of those. But the thing I was really interested in is because of my understanding and working with Bob Anderson, is, will people who are educators in the room, how will they stop being experts? Will they be able to adopt the model that we've tried to put in place, which is around helping people, helping engage people, helping people talk about their own stuff, right?
Mm-hmm.
And what's getting in the way. And the bottom line is, we did for the immediate educators, because there was, we almost handpicked the initial educators from across the country in the pilot sites for the research. So like any research, we did well because they were really engaged with our passion. But as it started to roll out, we were thinking, oh, I don't know. And of course, I noticed that some of my peer trainers, you know, not educators, the people that were training the educators, they were dominantly dietitians, and they wanted to deliver content, and they wanted to come into the room as experts, right? So I was leading the quality assurance program for this program, and instead of just going as the content delivered, we worked hard to get the Leicester Diabetes research team to focus on behaviours. So we developed this tool. And then I kept saying to one of the professors, saying, well, I don't think this is fit for purpose. And she said, well, we're going to need a quality assurance tool. So for the other programs that we're developing, would you like to study this? Would you like to do a piece of research? I went, I'm not a researcher. I said, but if you funded me to do a PhD, I'll do it. That's what I did, right? And she went, yeah, of course. So I spent 7 years doing a part-time PhD. I videoed. Well, I refined the tool. So I know a lot about how do you... validity of assessment tools, especially when you've got 2 or 3 observers, you know, looking at something. Are we all seeing the same thing? Absolutely fascinating. So anyway, bottom line was, our tool was not fit for purpose because it didn't describe the behaviours of the theories that our programme was based on.
Mm-hmm.
So I worked hard to find, so if you were delivering a programme based on social learning theory, what would you expect the educators to be doing when they're in the room? And of course, very little is out there. Where there was Bob Anderson's Empowerment. They had described educator behaviours pretty nicely. So I redefined the behaviours, and then did some work with colleagues to make sure the validity was reasonable. It was never brilliant, it's never going to be brilliant, but it was as good as it could be based on other research. And then I analysed nine programmes of 6 hours. I mean, it was a long, long, laborious journey of analysing behaviours in the room. Which behaviours were the easiest for educators to deliver, and which were not? And I mentioned that I never published this because I thought my career was ending, right? I'd done the job, done it all right. Let's sail into retirement now, Sue. Well, that was 10 years ago. Still not. But I did present some of my work at a conference I was asked to speak at in the last couple of weeks. And of course, I pulled out the old slides, and they engaged easily in managing the groups. They managed time, did like that, all of that. What they didn't engage easily with is the behaviours that were there to help engage participants and to support expression of emotion. Because that was one of the things about empowerment. You have to help people talk about what they're feeling, right? And I remember back on my interviews with the educator group, because I went back to them and said, because I took the tool back and all the behaviours, say, are these valid for you? Are these the things you think you should be doing in when you're in the room with people with time? Yeah, they're all important, all important. So I've checked that it was okay to be asking educators to be noticing emotions, not necessarily exploring emotions, but noticing them and acknowledging them. That's as far as we were wanting people to go. If they went further, that was great, but we were looking for what's the minimum we should expect when you're in it's a group program for 12 participants. And they couldn't do it. The majority couldn't do it. They couldn't do it. And a lot of that, I think, was because there was such a lot of dominance of content. So there's this other flag, which was, there's so much to teach, so much people to learn, and yet my colleagues don't seem to have realised that you only learn what you want to learn, right? And when it becomes important to you. So I think what you're doing is laudable, absolutely vital, but there's a context that you might need to be aware of. One is the system of care that is based on outcomes, metabolic outcomes.
Yeah.
2 is time limits for participants. and 3 is their own, actually it's 3 things, isn't it? Their own sense of self. So the talk I've done in the last 2 weeks has all been about, who are you when you're in the room?
Mm.
And I put a few slides around clean. One of the first ones, it wasn't so much clean, but I put the drama triangle in, and that illuminated things for people. You
Mm-hmm.
could see them in the room go. And I adapted it. I used some of Marion's work, and I put some of the phrases, and they all went, oh my gosh. And I could see them thinking, I think I might be a persecutor when I'm in the room.
Mm-hmm.
So I think, and so I would, and I was talking about, how do you get out of this drama triangle? Let me tell you what I've done. So I then moved very briefly over to a slide that I had something like, I can't manage my diabetes like that. I just put this phrase up there. And I just put a few of clean language questions, the basics.
Mm-hmm.
What kind of that? Is there anything else about that? When you say what kind of can't is that can't? So I got people to think about staying with the person's words and talked about my journey. So I think the first piece of work is, where are they with all of this?
Mm.
And I think you will find there will be people like me that will go, yes, this is just what I've needed. Because when I found clean, I went, it strips me of my agenda. That was the biggest powerful thing for me. It stopped me having to get anywhere near thinking about what the right thing was to say. Just trust, lots of practice. Just trust that these questions will open up, and then trust your spirit. Gosh, passion in me, eh? Trust your spirit will help you notice what's important to that person, because that's what I found. Well, I don't know what you've made of that, but
And when trust spirit like that,
yeah,
then what happens?
I know it's not. It makes. I know I've got a power, so trust the power of the spirit. So it's not that I don't have power as a healthcare professional, but my power is giving that person space and time, which they rarely get in a healthcare consultation, even on the phone, to just stand still and think for a minute about what they are feeling about their diabetes at the moment. I might not use that word, but where are you with your diabetes? So I think Marion described me as somebody I've adapted clean. She talked about, no, it wasn't casual, conversational clean.
Yeah.
And I felt that's what I had to do to get to where I'm at. I had to bring it in and see how it fitted. But for me to be able to, so now it's, my power is giving that person that space and time to use as best as I can, help them use it as best as they can to decide what they want to have happen with their diabetes. As simple as that. Yeah.
But it's not obviously conversation to ask what kind of that.
No.
But it's so interesting that when
Yeah.
you do ask what kind of that,
Yeah.
people can answer it.
They can, once they get over the, I don't know. So I do one-to-one coaching. So there's another point I must come back to. Let me put about treatments, because that may be the other thing that's getting in the way. Expectation of treatments. So I've been supporting a brilliant colleague to start using his own passion around how he's put his type 2 diabetes in remission for about 6 years. He really wants to sell. He is selling, because he's now employed by various PCNs to deliver a low carb metabolic health course. I've helped him set that up because I knew, resource investigator person, knew the people to get involved with, knew the politics locally. He's now employed as a health coach. I noticed that there'd be a few that would struggle after the knowledge bit. So I do one-to-one coaching occasionally. I was paid for it. Now I'm doing it as part of Marks and my business. And I've used some conversational clean to get into it, but then I do the coaching model. And for many it works, but they have to get over that's a strange question. Yep, it might sound strange, but just sit with it for a minute and see what happens. But it took me a while. Well, I don't know if it took me a while, because already, see, I was very into this notion of get yourself out of the room, Cradock.
Mm.
Stop being so present in the room. But the clean gave me a way of being present in the way that was most helpful. Yeah, so I think there is a bit, because when you start doing it, it is weird for people.
Mm.
Yeah, it wasn't for me because I just loved it, but I know it's weird because I've seen. But if you then have the not courage, the confidence, trusting it, right? It's that I believe in
Mm.
this stuff, to say, well, I know, and I usually start off any conversation in the coaching. So when I've got an hour with someone, I usually say my style might be slightly different to what you've expected. So if you feel anything that's uncomfortable, just let me know, right? Just tell me what's happening for you, and I'll work with that. And anyway, yeah.
So the people you're coaching, are they people with diabetes?
Yeah, people with type 2 diabetes,
Hmm.
um, in the main, who have done the 6 sessions of the knowledge bit,
Hmm.
in a group online with Zoom, but after a few weeks are struggling, are
Hmm.
beginning to struggle and want a little bit more. Now, they often come to me expecting me to give them more information. So I make
Hmm.
it fairly clear that I'm not here to help you with more information. You have the knowledge. But my job is to help you make sense of that knowledge, if that's what you need, but actually to help you find out a little bit more about what's getting in the way for you. So I usually ask them, what do they want to have happen? And they usually say, I want to get back on track. So
Hmm.
we talk about, it's a very common phrase I hear, I want to get back on track, or I've fallen off the wagon. So there is something interesting, that there's this right thing to do. There's a right track, which I think
Hmm.
is the compliance model.
Yeah.
And we often end up talking and helping. They start talking about their emotions and how they feel about food and what's impacting on their stuff. And so we end up with these two people in their heads, or they might be balloons that get in the way, a dark balloon and a light balloon. People come up with all sorts of metaphors to explain this dichotomy that's occurring in their brain when they think about food, right? So there's the one that represents the ability to keep away from the foods they don't want to eat. They see that as a good, using different words.
Hmm.
And then there's the other one, which is often the word devil is used. It's interesting, that makes them go towards that food. And so we go beyond that and go, what would you like to have happen? And sometimes I'll do a little bit of acknowledging about food addiction.
Hmm.
There's a big thing in type 2 diabetes, which you're going to meet out in the States, food addiction. And I don't think we've acknowledged that. But I don't think it's just about the food. It's about whatever the comfort is that's needing to be
It's
dealt
going
with.
to be a combination, isn't it? I mean, like you mentioned the low carb thing, which makes enormous difference to what people eat,
Oh,
because if you can get into that, you sidestep the addictive
yeah,
stuff.
absolutely. Yeah.
But addiction is real.
Yeah. 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 Yeah.
So when you're coaching, what I'm hearing is you're being clean or cleanish. You've got a coaching framework, but you're not afraid if you notice a pattern that you think, oh, my years of experience suggest this piece of information might be valuable. You
Yeah.
step in with the information.
Yeah. Yeah. And usually what's the phrase that psychologists was used to almost validate their experience, that it's a common
Mm.
experience. Yeah. So
Yeah.
there's something, you are not unusual in it. So I usually say, so when are you aware of whether this might be true for other people, or is it just true for you? And they usually go, well, I think it's just me. And I go, okay. So I then go, would you like me to tell you what my experience is around that? And then I say, this is what I'm usually coaching people around, right? So my experience is that it's not just you. So I have, yeah, because it feels, so there's a lot of sadness in people with diabetes, a lot of sadness, a lot of shame, which I think has come about. So I talked about that in my talk. So I love the Brené Brown stuff around shame. But then how do you do something when you feel someone's shame? I think the health service or healthcare has encouraged that shame, that sense of
Mhm.
fear, that sense of I'm powerless, I can't do anything because I can't do what these doctors and nurses who do know better can do, or it'll come out as anger. And one of the things I wanted to just quickly get in, and I'm glad you've picked up on the low carb stuff, is that within the healthcare system, we've been giving people real expectation of the right thing to do, and it's wrong. Right? So there's two things. One is if you use insulin, whether you're type 1 or type 2, correctly, I mean, I don't think anyone should go anywhere near insulin with type 2 diabetes, injected insulin. If you've got type 1 diabetes and you expect to, we've expected people to think that if they just did it right, everything would be perfect. What twaddle? You know, it really makes me cross when I hear people talking about this. And you know, when you inject insulin, so much influences its way that works on the person's glucose level, right? And
Mm.
we don't help people realize the crappiness of insulin, right?
Mm.
Injected insulin does not work the same way as endogenous. So there's one, right? So we set them up to fail a bit. So part of the job that people like me are doing is helping people unravel that guilt around there.
Mm.
Then, of course, there's the low carb stuff, which we're still battling. I think the battle is nearly won in the UK, but I've been part of the Public Health Collaboration. Have you heard of them?
No,
If you're in, I mean, you're not doing your
I'm,
work.
I'm very curious, but
Yeah. So they're a charity that's got some major funding from an entrepreneur at the moment. So they're doing big stuff that was set up to try and get rid of the Eat Well plate on the NHS
Mm.
website. That's their main predominance, and to influence peer educators across the country, ambassadors, to help people do something different because the NHS wasn't doing it.
Yeah.
And so there were Public Health Collaboration, you'll find it. And oh, I've done where I was going with that one. Yeah, so much coming out. So I'm full of stuff and I never know where to put it.
And I'm so excited by everything you're saying here, and I'm also trying to keep track of the bit that I need to know, which is the the sense that here you are, a person who, as I understand it, has had a full career in helping people with diabetes. Now in your later years doing the coaching thing rather than working it full time in healthcare, but you're still doing the thing. And you're using clean to help people with diabetes to manage their condition.
Yeah.
And that's what you've been doing for a while.
I've been doing that for a while, but I'm also still working as a diabetes specialist nurse.
Mm.
So I do the coaching work, now doing it privately with Mark. I was employed, but I don't think I was good value for money for the PCN, and I was ready to let it go. So I said, that's fine. But I also work 10 hours a week as a diabetes specialist nurse. So I come into contact. I usually do phone clinics.
Mhm.
I don't know if you picked up how old I am. I'm 72. So I'm still going, as you can see, still with passion, a lot of drive. So the specialist nurse work. So I have 20 to 30 minutes on a phone call to
Mhm.
people at random I've been asked to call. And I still use a bit of clean because it makes me take a deep breath, listen to that person. What do they want to have happen? But I know that there's something that goes on for me, and I probably might examine this a bit more, that there will be people at the end of the phone that just want to be told the next thing to do with their insulin. But
Mm.
I will usually want to go, so when you ask me that question, if I could tell you that, how will that help you? So I still try to use it in an engaging way. What difference will that make? So I think those are the sorts of phrases I was using before clean. What difference will it make to you? So I'm always trying to find things that will engage that person in what they're doing for self. But a lot of people are got district nurses coming in, so I'm talking to district nurses about adjusting insulin. Yeah, so it's a mix in there, but I know that my colleagues have noticed my style and
Mm.
they're interested in that. But I'm also curious that they talk about being interested, but when I offered to help my colleague dietitians who run the education programs to provide them some training around a different approach when they're in the room, they didn't really take it up. So they still believe that knowledge and PowerPoint slides are the way forward. No,
Isn't it interesting?
very interesting. And I notice it more in dietitians. than I do nurses. So it's going to be interesting, because I think the group that you're going to are a mix of all sorts. But I think nurses have a stronger desire. Oh, this is so broad, but my sense is the majority of nurses, that except those that want to be nurse practitioners and do diagnosis and treatment. So there's a group of nurses that want to follow the medical model, but there's a group of nurses that you will meet out there that do want to find a way of helping people in a significant way, but the current system is not supporting them. So that's why Bob and Marty had lots of people coming to their workshops, but not all of those people could take this model on, because they went back to the environment that was supporting their compliance orientated behavior. I hate that phrase. Mark, who I work with, he is now running groups, and the reason I worked with him is because I knew that he would be tempted to go down the knowledge route, because he's the man he learned it for himself. Mark fits into the highly activated, right? He doesn't need anything, right? Occasionally, so I did do a little bit of a coaching session when he had a real worry about something that was happening to him, and he loves watching me facilitate, loves me noticing words. So I think that's my superpower. I notice the it's almost like the words flash as people talk. Some words stand out to me, which is what happens, I think, with clean, isn't it? Really, you become a really good listener, and you tune into this thing here. And you go, that's a really important thing for you. Let's just pull it out a bit. And so he's now working with coaches, health coaches, and he's just actually told me that we've got more opportunities, because our business, the reason I'm still interested in our business is I want to train people. I know our training isn't as clean as I'd like it, because Mark isn't as clean as I am, because he's getting such good results with this approach at the moment. And I'm not going to say that's wrong, am I? I'm going to, but I think I want to use clean a little bit more with our training as we start to move towards 2 sessions, whole day training of coaches who are now going to be starting to work more with people with diabetes. So that's what I was interested about that. And then maybe if you look at the PHC website, they have ambassadors, and they may be interested in doing some training around engage. I love the notion of engagement and empowerment. The other thing just that clicked into my head then was around patient activation measure. They felt that healthcare professionals, so I think the reason it wasn't taken on board is the arrogance of healthcare professionals. They said, we don't need it because we know how activated our patients are, and I think just that phrase says something itself. We know how activated, and that might be true. You might have an intuition, but that also that shuts someone down. There's an assumption in that you put them into a box, one of those 4 boxes, and that's it.
They're not going to move between 1, 2, 3, and 4, which is the point, is to move them.
Absolutely. And I think, and just let me get this off my chest, and then I'll be silent for a little while. Oh, we're nearly finished. I think it's because healthcare professionals don't know what to do in the room next. And that is what my whole talk was about the last few weeks, was because I asked, unlike doing an expert talk and then asking for questions, what I did was ask for questions first. I said, so if this was to go just as you'd like, what would you get from it? Only 2 people put their hand up, and both of them went, I want quick wins. How do I get some quick wins in my consultation? The other one went, I would have loved to have stayed with that. And the other one went, I want some nuggets to help me, some words of wisdom nuggets. Because I said, what kind of nuggets? Words of wisdom. So I went, okay, I've got both of those, I think. So it was lovely.
What was the conference?
So it was the Trend Diabetes Nursing Conference, heavily sponsored by drug companies, but I wasn't sponsored by a drug company. I know we were asked to present 3 times. I couldn't do the third one. So they did one in London, one in Birmingham, one in Newcastle. I couldn't do the third one. So my colleague, Florence Brown, who's big on empowerment as well, but hasn't done clean, she's gone down a counselling route, which is really interesting. But I don't think she still works with people with diabetes like I do. So we talked about our stories. So the talk was really about a merging of our stories and how we came out the other end. Florence doing empowerment counselling course, and me doing clean language coaching approach, and how it fitted. But I'm the one still working. I'm not the one that's burnt out. You know, health coaches in the NHS are not paid a lot, but it wasn't about the money. It's not about the money. It's about, and I think the work I did with Trend recently at the conference just made me realize clean is still really much part of my life. There is something about getting to the spirit of people. So I think, and that's what clean does, I think, in a way that Bob had a model that he used to help us illuminate our spirit, and I'll send you that paper as well. Oh, perhaps no, perhaps it was just a workshop list, where he put a case study up. How would you, when this person walks out the room, how would you know if you succeeded or failed? And that starts to illuminate and develop a conversation. I mean, I used it years ago with the team I worked with then. And it was really interesting because for me, it was about, I'd given them time and space to talk about what they wanted to have happen. I might not have used those words then because that was pre-clean. But it was time and space, and I'd heard what they wanted, and we may have developed a plan. My other colleague said if they'd made another appointment, that was a sign of success. And I went, whoa, I'm not even bothered if they've made another appointment. It depends what's in the plan, right? Really interesting how those two questions just illuminated healthcare professionals, because it almost tuned into the compliance model, right?
Yeah.
So it brought it into the room. This is the thing you're up against, guys. You are trained in this. The system expects this of you. People with diabetes expect to be compliant, and they want you to help them find the switch. Anyway, whoa. One of the things for me with listening to you, Judy, is that I've done all the talking and I haven't, but it's lovely. My dad died at 88 after living with type 1 diabetes for over 60 years.
Wow.
Yeah, he did all right, right. And guess what he did?
Yeah.
Carbohydrate counting, right? He always controlled his carbs. Something in that, I think. They started off, well, apparently in a rough time. You know, there weren't as many insulins, there wasn't blood glucose monitoring, which is what it was like when I started nursing, because I started nursing in 1970, and glass syringes. So it was tough, but the rigidity of it probably has meant for many of them, if they could manage that they've done very well. But I do think there's also people that, I think there's a difference in type 1. Some people, when I watched people, sometimes it was really hard to manage their own diabetes, and others it was a bit easier, and it wasn't just about the effort. So I think there's something that metabolically goes on for some people.
Yeah, slightly different for different people.
Yeah, absolutely. So, but no, I mean, and a lot of people go, did you go into diabetes because your dad? No, I didn't actually. I went, because diabetes specialist nursing wasn't a thing when I was nursing. I think I went into it because of opportunities, but realised I actually wasn't a nurse. I was an educator. You know?
Yeah.
As I was a ward sister for a number of years, and realised that actually what I wanted to do is help these people not come into my ward with medical issues. I wanted to help people be better, and I wasn't afraid of hypos. That was the other thing, I think, because I lived with them. But anyway, it's all literally coming out. Sorry, I am really an external processor, but
I'm absolutely loving everything you've said. Thank you very much indeed for making time. I'm going to need to go, but
yeah, absolutely.
this is going to be the first of many conversations